Welcome back to the Deep Dive. Our mission here, as always, is to take a dense stack of sources, articles, research reports, and raw clinical data and turn them into instantly applicable, synthesized knowledge for you, the learner.
Mm.
Today, we're plunging into a subject that, well, fundamentally anchors how an individual perceives and interacts with the social world. Paranoid personality disorder, or PPD.
That's right. And, if you were to ask most people what paranoid means, they'd likely describe someone who is just suspicious.
Sure, or maybe just very cautious.
Exactly. But when we transition that word into a clinical diagnosis, paranoid personality disorder, we are moving far, far beyond mild suspicion. We are diving into a fundamental, an enduring and pervasive alteration in social reality processing.
So it's a whole worldview.
It's a profound, rigid, and deeply entrenched mistrust of others. It's characterized by a fundamentally cynical view of the world. The world isn't just complicated, it is actively, ceaselessly hostile.
And the diagnosis places PPD squarely within cluster A of the DSM-5-TR, which is known as the odd or eccentric cluster. So that puts it alongside schizoid and schizotypal personality disorders.
It does.
But the experience of PPD, both for the individual living it and for everyone in their orbit, it just seems uniquely intense and stressful compared to, say, the emotional detachment of the schizoid or the oddness of the schizotypal.
Oh, it is intensely stressful. And that's because the core experience of PPD is perpetual danger. The defining metaphor here is what we call the hostile theater.
The hostile theater.
For the individual with PPD, the universe is not a neutral stage where things occasionally go wrong. It is, by default, a hostile environment where malevolence is the standard operating procedure for almost everyone they encounter.
Wow.
So their need for constant surveillance, their hypervigilance, it's not experienced as a character flaw or, a mental illness. It is viewed by them as a necessary survival skill in a world they perceive as constantly threatening.
And a world that requires immediate and aggressive defense.
Exactly.
That is such a critical framing. A hypervigilance for survival. You're arguing that the pathology is really an overadaptation.
It is.
And our sources point out a serious clinical gravity to PPD that is, well, it's profoundly underestimated by the general public and sometimes even by clinicians.
Undeniably. The irony of the disorder is that these individuals rarely, if ever, seek treatment voluntarily for the PPD itself.
Why is that?
Well, because the pathology dictates that they cannot trust authority, especially someone like a therapist who holds power or claims to offer help. To seek help is to make oneself vulnerable to exploitation.
Of course.
So they typically only enter the mental health system due to external pressure. A spouse giving an ultimatum, the legal system demanding intervention, or most commonly, they present with severe secondary conditions.
Right, like somatic complaints, chronic anxiety, or major depressive disorder, which then masks the underlying personality structure. That makes the diagnosis challenging right from the start.
Right.
Okay, let's unpack this. We have comprehensive research report excerpts, including the rigid DSM-5-TR criteria, extensive NESARC epidemiological data that really reshapes our understanding of prevalence, detailed etiological models focusing on trauma, and specific treatment protocols like cognitive analytic therapy. Our mission is to move past the casual use of the word paranoid to understand the clinical depth of PPD.
Yes.
Its surprisingly high frequency, the surprising roots in childhood adversity, and the profound challenges of forging trust in a therapeutic setting built entirely on distrust.
It's a dive into the architecture of suspicion itself.
Let's start with the hard data. When we discuss personality disorders, the perception is often that they are rare outliers, affecting only a fraction of the population. But how common is this pervasive, enduring distrust based on the largest population studies?
Well, for that, we have to turn to the NESARC data, the National Epidemiologic Survey on Alcohol and Related Conditions.
Right.
And we use it because it's one of the most comprehensive community surveys of psychiatric conditions conducted on a massive, nationally representative sample. And this data is critical because it captures people who are not necessarily seeking treatment.
Which gives us a much clearer, less biased view of true population prevalence than just relying on clinical charts.
Exactly.
What's fascinating here is the implication that PPD is far more common than many severe conditions that receive far greater public attention.
That's right. The data suggests PPD is a relatively common condition, potentially more prevalent than conditions like obsessive-compulsive disorder or even schizophrenia, which, tends to dominate public awareness when we talk about severe mental illness. The scope is just enormous.
So let's talk numbers. What does the rigorous NESARC data tell us about the general population?
Okay, so epidemiological data places the prevalence of PPD in the general population somewhere between 2.3% and 4.4%. The NESARC study, which had extremely high rigor and relied on detailed structured interviews, it lands firmly on the higher end of that. It reports a prevalence of 4.4% of the total adult population.
4.4%.
Yes. And to put that into perspective, using the 2001-02 data, that represented roughly 9.2 million U.S. adults.
Wow.
So when you consider that over 4 out of every 100 people you encounter might live in this chronic state of hypervigilant distrust, it stops being a fringe disorder. It becomes a significant public mental health issue.
And I imagine if we move out of the general population and into clinical spaces, that figure spikes dramatically.
It does. In psychiatric outpatient settings, the prevalence is markedly higher. For instance, in clinical populations experiencing chronic distress or severe anxiety, PPD is often found as the foundational structure underneath those presenting symptoms.
And you mentioned an especially critical population, forensic settings. Why is PPD so frequently encountered there?
Well, PPD, due to the combination of symptoms we'll detail shortly, the persistent grudge holding, the aggressive counterattack, and the chronic suspicion, it's strongly associated with higher rates of aggression, hostility, litigious behavior, and even stalking.
Right.
The non-pathological world views suspicion as internal. The PPD patient, on the other hand, views it as a license for preemptive external defense. And that often translates into legal or criminal conflict.
Okay, here's where it gets really interesting, something that directly challenges traditional clinical wisdom. The gender breakdown revealed by the NESARC methodology.
This is a crucial nuance. Historically, PPD was widely believed to be much more common in men, and that was a consensus based largely on data collected from military, forensic, and inpatient settings.
Right.
However, the sheer breadth of the NESARC survey indicated a potentially reverse distribution. A higher prevalence in females, 5.0%, compared to males, 3.8%.
That's a massive discrepancy from the historical view. Why do you think relying on clinical or historical data led to that original skewed perspective?
Yeah.
And why is the NESARC data considered more reliable here?
Well, the NESARC methodology is key because it interviewed a massive, balanced community sample rather than relying on referrals. The traditional view likely suffered from significant diagnostic bias.
Okay.
As we discussed, men with PPD are often counted in forensic or correctional settings because their paranoia tends to manifest outwardly in aggression, physical violence, or, highly contentious legal actions.
They express their paranoia through confrontation.
Exactly. Women with PPD, on the other hand, may be more likely to present in community mental health settings or primary care, but their PPD is masked by highly comorbid conditions.
So what would they present with?
They might present primarily with severe anxiety, intense insomnia, or major depressive disorder rooted in chronic social isolation and the strain of maintaining relationships. If the clinician focuses only on the depression, they miss the pervasive paranoid structure underpinning it.
Got it. So the NESARC data forced clinicians to look past the presenting complaint to the foundational personality structure, revealing a higher rate among women than previously recorded.
Yes, precisely.
That makes perfect sense. The structure of paranoia acts as a foundational operating system. Let's look at the other programs, the co-occurring conditions or comorbidity profiles that frequently run on this system.
High comorbidity is the rule, not the exception, for PPD. When we look at axis I disorders, conditions like anxiety or mood disorders, we find strong links to major depressive disorder, often chronic and severe, agoraphobia.
Which is fear of public spaces, often rooted in the fear of exposure or persecution.
And obsessive-compulsive disorder, or OCD.
The connection to OCD is surprising. How does pervasive suspicion link to the need for ritual or control?
Well, the link is often about control and safety. The paranoid individual perceives a world constantly threatening them. So OCD behaviors like excessive checking, cleaning, or ordering can become pathological attempts to establish a predictable, controllable environment, thereby reducing the perceived external threat. The rituals become a defense mechanism against a chaotic, malicious world.
And the source specifically highlights a dangerous intersection with substance use disorders. That sounds like pouring gasoline on a fire.
That analogy is pretty accurate. That link is absolutely critical in terms of clinical management. For an already hypervigilant, suspicious mind, the introduction of certain substances can be disastrous. It can push the patient's system into high alert chaos.
What kind of substances are we talking about?
Specifically, stimulants like cocaine and amphetamines are notorious for powerfully exacerbating paranoid ideation. They often induce transient frank psychosis, a temporary break from reality centered on persecutory themes. Even cannabis, particularly high-potency varieties, has been shown to temporarily increase suspicion and distress.
So a PPD patient who is already walking the line of suspicion might use a stimulant for a lift, and suddenly they're experiencing fixed delusions.
Precisely. They cross the line from PPD's overvalued ideas into delusional thinking. Managing this substance co-occurrence is paramount in treatment and often requires immediate abstinence before any real psychological work can begin.
And how about other personality disorders? Does PPD overlap significantly with others, particularly in cluster B?
Yes. There is a common genetic and symptomatic overlap with the rest of cluster A schizoid and schizotypal, but also with cluster B disorders, specifically narcissistic and borderline personality disorders, which share that trait of externalizing blame.
Let's elaborate on the comparison with narcissistic personality disorder, as both seem to involve extreme self-focus, entitlement, and a refusal to accept blame.
They absolutely share the mechanism of externalizing blame, rarely accepting responsibility for failures, and both can exhibit a grandiose, sort of superior air. But the fundamental motivational engine is the key difference, and it's a vital insight for you, the listener. The narcissist fundamentally craves admiration and praise. They need validation that they are unique, special, and flawless. The PPD individual, in contrast, fears persecution and humiliation.
Can you walk us through a concrete scenario? How would a narcissist and a PPD individual react differently to the same professional criticism?
Sure. Imagine both are given a negative performance review by their boss. The narcissist would likely react with indignant rage, arguing, "This review is clearly wrong. My boss is jealous of my success, or they simply lack the capacity to appreciate my genius." Their goal is to maintain the perfect image. They want the boss to apologize and admire them.
Okay.
The PPD individual, however, might react with intense, rigid suspicion. They would immediately interpret the review not as a reflection on their performance, but as definitive proof of a plot.
So they'd think something like,
They'd think, "This review is step one in a campaign to discredit and terminate me. My colleagues must have fed the boss false information, and now I need to gather evidence to prove the conspiracy before they strike again."
right, so their goal is not admiration, but preemptive defense against an attack they believe is imminent.
Exactly. The narcissist wants to be worshipped. The paranoid individual wants to be safe from attack. Their core emotional drives are fundamentally opposed.
That distinction, admiration versus persecution, is immensely helpful for understanding the engine driving the behaviors. That sets the stage beautifully for diving into the diagnostic architecture. Let's signal the shift to the core diagnostic manual, the DSM-5-TR.
Okay.
Our sources emphasize that the diagnosis requires a pervasive distrust indicated by 4 or more of 7 specific symptoms. And we need to stress that these beliefs are unjustified in objective reality. They are projections of internal fears onto the external world.
That unjustified nature is the very essence of the pathology. We are analyzing what happens when there is a catastrophic failure in social processing, which clinicians refer to as an epistemic trust failure.
An epistemic trust failure.
Yeah. The individual has fundamentally lost the ability to accept social information. A friendly smile, a helpful instruction, a neutral social cue at face value. They have to operate under the assumption of deceit until, hypothetically, proven otherwise.
Though the goalposts for proof are often moved constantly, ensuring the suspicion is never truly extinguished.
Right.
Let's break down these 7 pillars or symptoms that define this profoundly guarded way of being. Starting with number 1, unjustified suspicion of exploitation or harm.
This is the baseline state, an active daily anticipation of betrayal. It's not just cautious. They feel an imminent, persistent danger, even when the environment is objectively safe.
So what does that look like in daily life?
Well, clinically, this manifests in pervasive misinterpretation of mundane social dynamics. If they start a new job, a new colleague is instantly interpreted as a rival sent specifically to undermine them, not a potential friend or collaborator. If a neighbor begins a mundane renovation, the PPD patient might obsessively track it, convinced it is a deliberate, malicious attempt to cause damage to their property or quality of life, maybe to reduce their home value.
And the mechanism driving this default to threat interpretation is called the hostile attribution bias.
Exactly. The individual's cognitive architecture defaults to interpreting ambiguous stimuli as threatening or hostile. If a person is texting while walking and accidentally bumps into the PPD patient, it's not seen as an accident due to distraction.
It's a provocation.
It's interpreted as a deliberate provocation, a sign of disrespect, or a premeditated attack. This failure to attribute benign or neutral intent to the actions of others is a hallmark feature of PPD.
Moving to the second pillar, preoccupation with unjustified doubts of loyalty. This sounds like it makes any sustainable intimacy almost impossible.
It does. Because of the hostile theater analogy, every relationship, friends, associates, partners, is under constant, intense, often debilitating surveillance. These people must continually pass intense tests of loyalty, tests that are often impossible to pass because the criteria are opaque and constantly shifting.
And a tiny slip-up is seen as proof of betrayal.
Exactly. If a friend misses a call due to being busy or makes a minor social slip at a party, it is immediately interpreted as confirmation of deep-seated treachery or malice. This isn't just a brief doubt. It's a consuming obsession that dominates their thoughts about the relationship.
And this leads directly to the tragic consequence you mentioned, the self-fulfilling prophecy.
Precisely. The relentless surveillance, the constant questioning, and the need for reassurance eventually become completely exhausting for the friends and partners involved. People eventually withdraw. They need space from the intensity.
And when they withdraw,
the person with PPD interprets this as the definitive, undeniable proof of their original suspicion, that they were disloyal and treacherous. This confirms the paranoia, cementing the belief that I was right all along, and perpetuating the cycle of isolation. They manufacture the very betrayal they fear.
Pillar 3, which presents a colossal challenge for therapists, reluctance to confide.
This is a massive internal and external barrier. The warranted fear here is profound. Any piece of shared information, no matter how benign, will be saved, recorded, and later used maliciously against them for blackmail, humiliation, or social destruction.
Right, so that fear drives intense secrecy, guardedness, and emotional distance in all aspects of their lives. And how does that manifest when they are forced into treatment?
When they enter a therapeutic setting, they often view the clinician not as a helper or confidant, but as an interrogator gathering evidence. If the therapist asks about their childhood, the PPD patient fears the therapist is collecting ammunition to psychoanalyze them publicly or report them to some authority.
So the basic act of self-disclosure, which is the foundation of therapy, is pathologically interpreted as a self-sabotaging act of vulnerability.
It is.
Let's look at the fourth symptom, reading hidden meanings. This is where the interpretation disorder runs rampant, filtering everything through the lens of threat.
Yes, it's a filtering disorder. Mundane events, neutral social interactions, or benign remarks are consistently filtered and seen as demeaning, threatening, or hostile. The classic example in the literature is receiving a sincere compliment.
Right.
A genuine remark like, "You look very sharp today," might be reinterpreted internally as, "They are pointing out that I usually look terrible, and this is a subtle way of criticizing my professionalism."
That sounds like it requires tremendous energy and must be rooted in something fragile internally. Is there an underlying fragility of self-esteem driving this constant threat detection?
Absolutely. The hypervigilance is a pathological defense of a highly fragile self-concept. They are constantly scanning their environment for external validation or, more often, external criticism because they harbor a deep, often unconscious internal belief of inadequacy. They project that insecurity outward, constantly looking for confirmation from others that they are, in fact, flawed or worthy of attack. The constant scanning is a desperate attempt to stay one step ahead of the perceived inevitable criticism.
Pillar 5 deals with time and an emotional ledger, persistently bearing grudges.
This defines the unforgiving nature of PPD. They are incapable of letting go of perceived insults, injuries, or slights, even minor ones that occurred decades prior. They maintain a precise, often meticulous mental ledger of wrongs, and they ruminate on these past attacks, frequently plotting future retaliation or public exposure of the wrongdoer. This rumination keeps the emotional injury fresh and active.
Why is forgiveness so impossible in the PPD worldview?
Well, in their operational schema, forgiving an offense is seen not as a virtue, but as a sign of profound weakness. Weakness, in the hostile theater, invites further, more severe attacks.
They have to hold the grudge.
They must hold the grudge, sometimes indefinitely, because it is necessary self-defense against perceived systemic injustice. Entire families can be permanently ruptured over disagreements that happened during their childhood simply because the PPD patient cannot erase the ledger.
Then we get to number 6, which directly explains the high frequency of aggressive and litigious behavior. Perception of attacks on character, followed by a quick, angry counterattack.
This is the explosion point, often characterized by righteous indignation. They have an extreme hair-trigger sensitivity to any perceived criticism, slight, or public disrespect. If they feel their character, reputation, or professional standing has been attacked, even indirectly, they react quickly, angrily, and aggressively to counterattack and restore what they perceive as justice.
We see this often translate into a profound tendency toward official complaints, don't we?
Yes, highly litigious behavior is a hallmark. They bypass social negotiation. Instead of discussing a perceived slight with a manager, they might immediately file formal complaints, engage in protracted legal battles, or even lawsuits over incredibly minor perceptions of harm.
Wow.
This need to aggressively restore justice is driven by the profound threat that criticism poses to their fragile sense of self. It's also why PPD is a strong predictor of aggressive incidents in structured settings, because their tolerance for perceived disrespect is virtually zero.
Finally, Pillar 7. Focusing on intimate relationships. Recurrent suspicion of fidelity.
Pathological jealousy is a common and dangerous feature of PPD, and the key is that it occurs without justification or objective evidence. This chronic, baseless suspicion leads directly to profoundly controlling, invasive behaviors.
Like what?
They may obsessively check a partner's car odometer, demand access to private emails or text messages, or make surprise visits to track their partner's movements and test their veracity.
And the sources note the specific, extreme danger associated with this symptom when combined with the other features of PPD.
This is a critical point that demands attention. When pathological jealousy is paired with the unforgiving nature and the aggressive counterattack of PPD, it is unfortunately noted as a significant precursor to severe domestic violence and, tragically, homicide in the most extreme cases. The unchecked suspicion and the need for absolute control can escalate dangerously in intimate relationships, making this symptom an acute risk factor that clinicians and partners must be aware of.
Those 7 pillars provide a chilling picture of an entire way of life, a structure built entirely on the expectation of malfeasance. Before we transition to etiology, let's cover the critical exclusion criterion. Criterion B, exclusion of psychosis.
This is vital for clinical diagnosis. The PPD diagnosis is only valid if these pervasive personality symptoms do not occur exclusively during the course of a frank psychotic disorder, like schizophrenia, bipolar disorder with psychotic features, or substance-induced psychosis.
So, the paranoia in PPD is based on overvalued ideas, meaning they are intensely held and affect behavior, but they lack the complete, unshakable conviction and bizarreness of a delusion.
Exactly. The PPD patient is usually still responsive to contradictory evidence, even if minimally and temporarily. They may say, "I still don't trust the evidence," but they won't say, "The evidence is wrong because the CIA planted it in my filing cabinet using gamma rays." The delusional disorder patient lacks that capacity for reality testing regarding the core delusion.
But the sources also mention the premorbid qualifier, acknowledging the overlap with the psychosis spectrum.
Yes. If the PPD symptoms, the suspiciousness, the rigidity, the social isolation, are clearly present in defining the patient's functioning prior to the actual onset of schizophrenia, we add the label paranoid personality disorder, premorbid.
Right.
This acknowledges the shared genetic vulnerability, suggesting PPD can sometimes function as a prodrome or precursor phase to full-blown psychosis. Though it is important to reinforce that the vast majority of individuals with PPD never progress to schizophrenia.
Okay, that clarifies the structure. Now, let's unpack the why. If this disorder is a structural way of being, where does it originate? Let's move to section 3. Etiology, focusing on the powerful intersection of the trauma model and biological vulnerability.
We have to approach this through the double hit model. It's a synthesis where a latent biological vulnerability, a kind of genetic tinder, meets profound environmental adversity, the match, which shapes that risk into the specific form of paranoia and hostility. The PPD is not just random bad luck. It's a specific learned response layered onto a biological predisposition.
Let's look at the childhood roots, because this is where the numbers are staggering and the psychological logic of PPD truly crystallizes into that over-adaptation you mentioned.
The trauma model offers the most compelling functional explanation. The paranoid stance is a logical adaptation to an illogical and genuinely dangerous childhood environment.
Logical adaptation.
Yes. And the core data point is one of the most sobering in all of personality disorder research. Approximately 78% of people diagnosed with PPD reported significant abuse and/or neglect during childhood.
78%. That figure completely reframes the diagnosis. It's not an eccentricity. It's a chronic stress trauma response.
Absolutely. It changes the narrative from this person is odd to this person is pathologically defended. And while general emotional neglect is damaging, the sources specifically highlight that physical and sexual abuse are particularly strong predictors for the development of PPD.
And that's a predictor they share with antisocial personality disorder, where interpersonal manipulation is also highly learned.
Right.
So how does this profound level of trauma translate into the specific mechanism of PPD in adulthood? How does that survival skill become a pathology?
Think about the child's environment. If a caregiver is volatile, sadistic, or deeply inconsistent kind one minute, violently abusive the next, the world is experienced as utterly unpredictable and terrifying.
So the child learns that trust is a massive liability.
A massive liability. Safety can only be achieved through hypervigilance. They must constantly scan the parent's face, tone, and body language for subtle shifts, the tightening of a jaw, a sharp intake of breath, to predict an impending attack and find an escape route.
They learn to look for threats that aren't explicitly stated.
Exactly. They learn to interpret ambiguous cues as dangerous because in their childhood reality, a neutral cue could easily turn into a disaster. The fundamental lesson they learn is, I cannot trust the environment, and I certainly cannot trust the people providing my care. They develop a generalized expectation of harm.
And as they grow up, that internal threat detector, which was necessary for survival at age 6, never resets when they move into the safety of adulthood.
That is the tragedy. That highly tuned survival mechanism becomes the disorder in adulthood. Even in a benign or safe environment, a kind partner, a supportive boss, they continue to scan for the threat they were taught to expect. The brain is running a childhood script on an adult stage. This continuous vigilance reinforces the hostile attribution bias, where every ambiguous signal is still incorrectly filtered as dangerous.
This logic also deeply informs their attachment style, doesn't it?
It connects perfectly. PPD is strongly associated with insecure, dismissing, or fearful avoidant attachment styles. The individual carries an intense internal conflict. They desire safety and connection because they are human, but they are fundamentally convinced based on empirical childhood evidence that anyone they connect with will eventually betray or harm them.
So connection means vulnerability.
And vulnerability means attack. Safety can only be achieved through radical self-reliance and, crucially, the preemptive rejection of others before they can inflict pain.
Now let's pivot to the biological layer underpinning this trauma response. What is the genetic signature that predisposes someone to interpret the world this way?
The clearest biological finding is the link to the schizophrenia spectrum. PPD is genetically related to both schizophrenia and delusional disorder, particularly the persecutory type. This suggests they share a common genetic vulnerability, a diathesis, possibly involving dysregulation in the dopaminergic pathways.
The dopamine is critical for salience, how we assign importance to things. How might its dysregulation contribute to paranoia?
Well, if the dopamine system is dysregulated, the brain might inappropriately assign high levels of salience or importance to neutral external stimuli. A PPD patient might walk into a store, see two people laughing, and their dopamine system flags this as highly important, highly relevant, and highly threatening.
Leading them to believe the laughter is directed at them.
Exactly. It's a system designed to look for threat that is permanently stuck in the on position.
But if they share a genetic vulnerability with schizophrenia, what provides that protective buffer? What keeps the PPD patient from moving into full chronic psychosis?
The key differentiating factor is generally found in cognitive control. The PPD individual retains enough cognitive control, the capacity for organized thought, complex problem solving, and reality testing regarding everything outside their suspicious domain, to avoid the profound disorganization, hallucinations, and bizarre delusions of schizophrenia. Their pathology is rigid, but generally organized.
And finally, let's go deeper into the neurobiology related to that constant hostile attribution, the mechanism of the threat detector being stuck on.
Hypotheses point strongly toward deficits in frontal-limbic connectivity. The limbic system, particularly the amygdala, is the brain's alarm bell responsible for processing fear and threat detection. The frontal lobe, the prefrontal cortex, is the executive control center. It's supposed to look at the threat signal from the amygdala and say, wait, is this a real threat or just a shadow? And then modulate or downregulate the fear response.
So what happens in PPD if that connectivity is impaired?
If the frontal limbic pathway is impaired, the frontal lobe cannot effectively inhibit the amygdala's alarm bell. The fear response is unchecked, constantly reinforced by external inputs, and the hostile attribution bias becomes neurologically ingrained. The PPD patient is essentially experiencing a runaway threat response, unable to switch off the deep, pervasive feeling that they are in immediate danger, even when logical analysis suggests otherwise.
That paints a complex and tragic picture, where a genetic predisposition is catastrophically magnified by early life trauma. Now this brings us to Section 4, differential diagnosis. The challenge for clinicians is differentiating PPD, which is pervasive but non-psychotic, from other conditions that also involve paranoia.
This requires tremendous clinical nuance. The distinction always hinges on three core factors: the quality, fixed versus flexible, the duration, transient versus chronic, and the pervasiveness, situational versus across all domains, of the suspiciousness.
Is the paranoia a symptom of a mood state, or is it a pervasive aspect of the person's personality structure?
Exactly.
Let's start with the most critical clinical distinction: PPD versus delusional disorder, persecutory type. The difference between that overvalued idea and the fixed delusion is incredibly subtle, but vital.
Absolutely vital. Delusional disorder involves fixed delusions, beliefs that are unshakable, often bizarre, and are held with 100% conviction despite clear, contradictory evidence. The delusion is usually highly focal.
Meaning very specific.
Very specific. For example, a person may be convinced, my upstairs neighbors are using electromagnetic waves to control my thoughts, and they will dedicate their life to proving this one highly specific plot. Crucially, outside of that encapsulated delusion, the person's functioning is often preserved.
And how does that differ from the PPD patient's overvalued idea?
The PPD patient's belief is pervasive across all domains, but it is not absolutely fixed. It's flexible enough to be slightly challenged. They might say, I am suspicious of every single new person I meet. They're all trying to undermine me. If a therapist gently introduces alternative, benign explanations, the PPD patient might concede, after immense resistance, maybe I am wrong about her, but I still don't trust the rest of the world. The delusional disorder patient would never concede.
Next, PPD versus schizophrenia. We've established the absence of criterion A symptoms, but let's reinforce the structural difference in thought.
The main difference is the absence of hallucinations, bizarre delusions, and profound thought disorganization in PPD. Schizophrenia involves a fundamental breakdown in the very structure of thought. The PPD patient, however, maintains a capacity for what appears to be internally consistent logic, however paranoid the premises.
Give us an example of that logical consistency.
The PPD logic follows a clear, defensible, even if ultimately false, path. I saw my neighbor talking to my boss. I know they hate me. Therefore, they are conspiring to have me fired. The paranoid conviction is strong, but the thought process itself is organized. While PPD patients can experience brief psychotic episodes lasting minutes to hours under intense stress, these are fleeting and situational, unlike the sustained, chronic psychosis of schizophrenia.
Let's compare PPD to a cluster B disorder, borderline personality disorder, or BPD. BPD is notoriously intense and often involves stress-related paranoia.
It does, but the paranoia in BPD is typically transient and highly localized, almost always triggered by an intense fear of abandonment, rejection, or loss of attachment.
Right.
The BPD patient is emotionally labile and intensely seeks dependency, validation, and intimacy, even if their relationships are chaotic. The PPD patient is rigid and fundamentally avoids dependency at all costs because dependency equates to vulnerability and vulnerability equals attack. Their emotional landscape is defined by cold suspicion, not volatile attachment seeking.
Moving to the other members of Cluster A schizotypal personality disorder, how do we differentiate that type of eccentric suspicion?
Schizotypal PD involves a much higher degree of eccentricity in magical thinking. They might believe in clairvoyance, have peculiar or odd speech patterns, or wear highly unusual clothing. Their suspicion often involves vague, non-bizarre ideas of reference like believing a radio message is meant just for them.
And PPD is different because
PPD, in contrast, is characterized by sheer hostility and rigid guardedness without the weirdness or the formal cognitive distortion of schizotypal PD. Their suspicion is focused on specific aggressive persecution.
And finally, schizoid personality disorder, which also involves profound social withdrawal.
This is the crucial distinction: indifference versus fear. The schizoid patient is characterized by fundamental detachment and a profound lack of desire for relationships. They're indifferent to others. They simply find social connection uninteresting, tedious, or unnecessary.
But the PPD patient is the opposite.
The PPD patient, however, is intensely fearful and consequently intensely obsessed with others' malicious motives. They withdraw not because they don't care about others, but because they are terrified of being exploited, harmed, or humiliated by them.
That comprehensive overview clarifies the clinical space PPD occupies, a pervasive, hostile, and non-psychotic structural alteration of the self. So given this profound structural rigidity and the chronic nature of the disorder, how do you even begin therapy?
That is the central problem of treatment. The disorder itself targets the very mechanism of the cure, the therapeutic alliance, which requires basic trust. The individual arrives viewing the therapist as a potential adversary, an authority figure who might exploit or pathologize them.
So traditional blank slate therapy would fail.
It often does, or it backfires, reinforcing their suspicion of hidden motives. The therapist has to adopt a specific, highly structured and transparent stance to build an alliance based on predictability and competence, not warmth.
Let's start with cognitive behavioral therapy, or CBT, which focuses on those paranoid schemas like, people are malicious, or I am perpetually vulnerable.
CBT is the most commonly researched intervention. It focuses heavily on modifying those deeply ingrained schemas. The objective is never to tell the patient they are wrong or crazy.
Because that would just cause them to defend the suspicion.
Exactly. And rupture the alliance. The successful approach must use careful cognitive restructuring driven by Socratic questioning.
How does Socratic questioning look in a clinical setting with a PPD patient, knowing how sensitive they are to criticism?
It's a very gentle, probing introduction of doubt. For example, if the patient says, "My boss frowned because he is clearly planning to fire me next week," the therapist wouldn't say, "That's ridiculous." Instead, they would ask a series of questions. They might ask, "That must feel very threatening. If we look at this situation objectively, is there any other benign reason your boss might have frowned? Could he have received bad news? Could he have a headache? Could he have been thinking about what he needed to pick up for dinner on the way home?"
The power there is that the therapist is positioning themselves not as a challenger, but as a collaborative investigator.
Exactly. The therapist avoids statements and relies on questions, forcing the patient's cognitive system to consider alternative benign attributions without feeling directly attacked or invalidated. The focus is on the possibility of alternative interpretations, which chips away incrementally at the rigid schema.
And what about behavioral experiments? Testing the schema in the real world seems risky, given their fear of harm.
They are crucial, but they must be carefully constructed and extremely low risk initially. If the patient holds the schema, "If I trust anyone, they will inevitably cheat me," the therapist helps them devise a plan to test this belief in a neutral setting. For instance, the patient might agree to intentionally trust a neutral, non-intimate person, like a clerk at the post office, with a very simple, minor request, and observe the outcome. Did the clerk exploit them? Did they treat them normally? The patient documents the neutral outcome, which provides empirical data that incrementally helps disconfirm the hostile schema.
And since PPD patients are prone to quick, angry counterattacks that drive people away, social skills training must be vital for breaking the self-fulfilling prophecy we discussed earlier.
It is fundamental. PPD patients often lack the skills necessary for healthy conflict resolution. Their defensiveness creates hostility in their environment, which then justifies their paranoia. So CBT includes teaching assertiveness, how to state needs and boundaries clearly and respectfully, instead of aggression or passive aggression.
I find the application of mindfulness particularly fascinating here. How can someone who is hypervigilant possibly calm their mind?
The specific technique used is detached mindfulness. It doesn't aim to stop the paranoid thoughts, which is impossible. Instead, it teaches the patient to observe a paranoid thought, such as, "I am being watched, and they are plotting against me," as merely a transient mental event, a thought, rather than a factual statement that requires immediate aggressive action.
So they learn to label the internal experience.
Yes, they might internally say, "Ah, there is the familiar thought that I am in danger. I recognize that thought, but I do not have to obey it." By creating a space between the suspicion and the emotional behavioral reaction, they gain a critical moment of choice, allowing them to engage executive control and avoid the automatic counterattack.
Now let's look at cognitive analytic therapy, or CIT, which seems to be showing specific promise by addressing those deeper relational patterns established in childhood trauma.
CIT is an excellent, time-limited, integrative therapy that specifically tackles how early trauma creates rigid internal maps of relating. It works by making these maps explicit and then helping the patient find the exits. One of the most powerful initial tools is the reformulation letter.
What exactly is this letter, and how does it manage to bypass the patient's fundamental distrust?
Early in therapy, often after 4 to 8 sessions, the therapist compiles their understanding into a written letter. This letter describes the patient's historical relational patterns, the trauma, the pain, the current difficulties, and the defensive behaviors, using the patient's own language and perspective.
And the power lies in validating the patient's profound struggle without validating the current irrational paranoia.
Precisely. For example, the letter might say, given that you experienced betrayal and abandonment so severely as a child, it is completely understandable that you approach every new relationship with the expectation that they will become your abuser. By articulating the patient's own defensive patterns, the therapist achieves something critical, shared understanding.
The patient thinks, this person sees me, they understand my defense, and they are not criticizing me.
Yes. And that shared understanding is a huge leap toward therapeutic trust.
And CCAT introduces the concept of reciprocal roles. What are those internal maps PPD patients are operating on that guide all their interactions?
Because of the massive trauma statistic, PPD patients primarily operate on rigid relational maps that reflect their past. The most common are the roles of abuser, left-right hero victim, or attacker, left-right hero attacked.
Right.
Their past experience dictates that they are either going to be hurt or they must hurt first. Their defense mechanism in adulthood is to preemptively adopt the role of the attacker to avoid ever becoming the victim again. CTAT helps them map out how they keep themselves trapped in this dynamic.
So recognizing the trap allows them to see the way out, the exits.
Exactly. The therapist works with them to identify the self-fulfilling prophecy trap. I suspect you, right arrow, I act aggressively towards you, react defensively, or attack back, right arrow. I interpret this as proof that my original suspicion was correct. This trap reinforces the original trauma schema endlessly. The therapy focuses on finding exits, new, non-attacking, assertive, and transparent ways of relating that break the cycle.
It seems like the entire practice of PPD therapy revolves around the fact that the therapeutic relationship is the therapy. How do clinicians manage the inevitable ruptures, where the patient projects their paranoia onto the therapist?
This demands an incredible degree of clinical skill, non-defensiveness, and patience. It requires 2 key constant strategies: radical transparency and active rupture repair.
Okay, what do you mean by radical transparency?
For transparency, the therapist must eliminate all ambiguity, which is the PPD patient's fuel for panic. If the therapist needs to take a note, they must explicitly state, I am writing down the key point you just made about your boss so I don't forget it and so we can refer back to it later. If the therapist looks at the clock, they must explain, I am looking at the clock to ensure we finish precisely on time, as I know predictability is important to you, not because I am bored or eager for you to leave.
Because the absence of a stated reason is immediately interpreted as evidence of a hidden malicious motive.
Always.
And when the patient accuses the therapist of malice, when that rupture inevitably occurs, that must be the highest stakes moment.
It is the ultimate test. The therapist must contain the projection without becoming defensive themselves, because a defensive reaction confirms the patient's suspicion that they are, in fact, an adversary. The therapist has to pivot from defense to non-defensive, collaborative investigation.
So what does that sound like?
A typical helpful response is, it sounds like you're feeling very criticized by me right now. That must feel incredibly unsafe. Rather than debate the validity of that feeling, let's look together at exactly what I said that triggered that specific feeling of being judged or attacked.
That is the core work of alliance repair, isn't it? Because that non-defensive, accepting, yet factual stance directly disconfirms the patient's deepest expectation of attack.
It disconfirms the core schema. The patient expects the adult world to behave like the traumatic past, to deny, to attack back, or to minimize their feelings. When the therapist maintains transparency, stays calm, and collaboratively investigates the feeling without accepting the paranoid content as fact, it provides the patient with a profound, healing, and corrective emotional experience.
That demands superhuman levels of self-awareness from the clinician. Let's move into our penultimate section, Section 6, Pharmacotherapy and Prognosis. Are there specific drugs designed to treat PPD?
Unfortunately, no. PPD is fundamentally a personality structure, a deep-seated way of relating to the world. Currently, there are no FDA-approved medications specifically for it. Pharmacotherapy is used strictly off-label for symptom management.
Just to dial down the distressing intensity of the paranoid thoughts and co-occurring mood symptoms.
Right.
Which drug classes are used to tamp down that intense suspiciousness or quasi-psychotic thinking that happens under stress?
Atypical antipsychotic second-generation agents like risperidone, olanzapine, or quetiapine are often employed. These have the greatest potential for impacting the cognitive perceptual symptoms. When used in very low doses, they can reduce the overall intensity and frequency of general suspiciousness, agitation, and those moments of quasi-psychotic thinking. They lower the volume on the constant threat signal.
And what about the high rates of depression, anxiety, and profound hostility we discussed earlier?
SSRIs are the workhorse here, used to treat the high comorbidity symptoms. Serotonergic agents are generally believed to facilitate a reduction in impulsive aggression and improve social cooperation. The literature specifically notes that paroxetine, for example, has shown evidence of reducing hostility even in non-depressed populations.
And what about acute anxiety, something to calm them down when they are truly spiraling with suspicion?
Anxiolytics, specifically benzodiazepines, are used for acute, severe anxiety or intractable insomnia, but they are used with extreme caution and only short-term. The risks are profound.
High potential for dependence and abuse.
Right, and critically, they can cause disinhibition. For an already hostile and guarded individual, this disinhibition can lead to increased impulsivity, potentially increasing the risk of aggression or violence. They are generally an absolute last resort.
The major challenge here isn't just choosing the drug, but getting the patient to actually take it. The pharmacological approach runs straight into the same distrust we saw in therapy.
That is the core pharmacological barrier. PPD patients are highly suspicious of medication itself, often viewing the prescription as a means of control, sedation, or even poisoning a way for the system to silence or incapacitate them.
So prescribing requires a huge amount of negotiation.
An extremely extensive and drawn-out process of negotiation. The prescribing clinician must be completely transparent about side effects, mechanisms, and dosage, often having to explain the same points multiple times to overcome that fundamental, ingrained distrust.
Finally, let's look at the long-term outlook. What is the prognosis for someone living with this pervasive structural disturbance?
The prognosis for PPD is generally described in the literature as guarded. Unlike cluster B disorders like borderline personality disorder, which often sees significant improvement or burns out as individuals reach middle age, PPD tends to be remarkably chronic and stable over the lifespan.
So the core traits persist.
They do. Longitudinal studies indicate that the core traits, suspiciousness, rigidity, and guardedness, tend to persist, defining their relational landscape for decades.
What toll does this long-term stability take on their ability to live a fulfilling life?
A heavy one. PPD is associated with significant and chronic impairment in social and occupational functioning. This includes high rates of divorce, prolonged periods of unemployment due to interpersonal conflicts with colleagues or supervisors, and severe social isolation.
Are there any environments where they can actually function well, perhaps utilizing their extreme vigilance?
Yes, and this is a hopeful note. Our sources note that some individuals can function well by finding specific occupational niches that capitalize on their need for vigilance and skepticism.
Like what kind of jobs?
Roles in solitary fields, or jobs that actively require constant checking, auditing, investigation, inspection, or security work can provide a good fit. These roles validate their suspicion as a necessary professional skill, provided they do not require close, collaborative, or intimate teamwork.
And we must return to that critical risk factor you mentioned earlier, the relationship between PPD and externalizing violence.
This is a consistent and serious finding. PPD is a significant predictor of violence risk. This risk stems directly from the dangerous combination of symptoms we reviewed. The persistent grudge holding, combined with the hair-trigger, aggressive response to any perception of attack. This toxic combination can lead to either impulsive, defensive violence or, more chillingly, premeditated retaliation or chronic stalking behaviors against perceived enemies.
So when we synthesize this entire dive, we see paranoid personality disorder as a profound disturbance in the capacity for human connection. It's not a choice. It's a rigid, entrenched defense mechanism, often rooted in that deep childhood adversity, meticulously designed to protect a vulnerable self from a world they were taught was inherently predatory.
That's right.
It is truly a test of clinical patience and empathy. The therapeutic challenge is undeniable. Asking the patient to forge a bond with someone, a therapist, even though their pathology dictates that all bonds, all acts of trust are inherently dangerous and invite exploitation.
While cure, in the sense of total personality reconstruction, is rare, the goal is always significant amelioration of suffering and functional improvement. By offering transparent, structured, and non-defensive psychotherapy, whether it's the structured evidence-based approaches of CBT or the relational mapping of C, the clinician offers a corrective relational experience.
They can help the patient lower that thick, thorny shield, even if just a few inches.
Yes. Allowing for a life that is less intensely besieged by the phantoms of suspicion and allowing for slightly more social connection.
This deep dive forces us to confront the fundamental human need for trust and the devastating consequences when that capacity is utterly broken, often rooted in childhood adversity that the individual never chose, had no control over. The existence of PP challenges us to ask, what happens when the survival instinct itself becomes the pathology?
Absolutely. And the path forward for research requires a deeper commitment to identifying the biological signatures, the biomarkers, that could guide treatment. If we could identify the specific neurological dysfunction driving the hostile attribution bias, for example, the precise circuit that fails to downregulate the amygdala's fear response, it might offer a unique pharmacological or neuromodulatory key to unlock this highly defended condition.
Offering relief beyond just managing the secondary symptoms.
Exactly. Something for you to mull over as you encounter the world this week.
That is certainly a powerful thought for us all to consider. Thank you for joining us for this deep dive into the architecture of suspicion.
Thank you.
Continue your own deep dive by checking out the sources and notes associated with this episode. We'll talk to you next time.